We can't hear you.
Is audible. Hello.
Ma'am, am I audible now?
Better.
So there was history of smoking cigarettes, 1 to 2 packs per day for last 5 years. There was history of smoking weekly, 11
I would urge everybody to kindly mute themselves,
for
please.
last 20 years. There was history of betel nut 4 times in a day for last 20 years.
Dr. Murlidhar, please mute yourself here. Dr. Murlidhar, kindly mute yourself. Thank you. Sure. Continue.
My symptomatology is over. So there is a active poll on the screen. If everybody could just put in what are the symptoms that I missed. For a case of CA, supraglottis, glottis, and subglottis.
Till the time you get the responses, Shinjita, could you just,
Yes.
educate us as to what exactly comprises of the supraglottis, the glottis, and the subglottis, as in the anatomical boundaries?
Yes, ma'am. So, ma'am, the supraglottis has anything above the level of the vocal cords, that is the epiglottis, the aryepiglottic fold, the arytenoids are in the supraglottis. And the false chord. The true chords, including the anterior commissure, is a part of the glottis, and anything below the level of the true chords is the subglottis.
So where does the vestibule lie?
Ma'am, the vestibule is a part of supraglottis.
Yeah, so if you look at literature now or many of these anatomical books,
Yes,
there are some references which say that the vestibule, anything up to the false chords comprises of the supraglottis, and the vestibule as well as the true chords comprise the glottis. There are some others which mention that only the true chords comprise the glottis. So the vestibule is, kind of a no man's land, but predominantly it is still considered a part of the glottis rather than the supraglottis. Supraglottis ends at the false chords.
okay. Yes.
I mean, all of you all can also read up, and then, this is a very commonly asked question if somebody wants to really trouble you.
Okay.
Have we got the responses on that poll?
Ma'am, I'm not sure about the poll. So we'll move on with the presentation.
No. So then let's come to, then in that case, let's make it the conventional way about the symptomatology. So you're pointing towards a hoarseness which which was the first symptom. So you're
Yes,
pointing towards which subside in particular? I mean, the larynx or the
ma'am.
hypopharynx?
Larynx, because the complaints of the patient started with hoarseness of voice.
I'm not crying.
Everybody just mute themselves. Yeah.
And we have one response.
No, but I think you included difficulty in breathing.
Yes.
I remember. So Strider doesn't really hold good. And when you said the patient had cough while swallowing liquids and not solid, what are you implying?
Ma'am, so if if the dysphagia is more for liquids, then it is to do if the dysphagia is more for solids, it is to do something with the physiology. Uh, if it is for liquids, then
No, you didn't mention about dysphagia. You mentioned about cough,
yes,
hasi.
ma'am.
Yeah. So when you're saying that there is cough while taking liquids, what are you actually directly indicating? Mane hit straight away hit the point. Now, what are you indicating?
Uh, cough, ma'am. Sorry, ma'am. Could you repeat?
So you mentioned there was the patient complains of cough while taking liquids, right?
Yes,
What are
ma'am.
you directly indicating?
So, ma'am, he has history of, as in he has some aspiration, which is
Absolutely. So the another response that you got is aspiration, but I think you very elaborately took that history to then tell us that it was cough while taking liquids. It directly tells us that the patient is aspirating. Yeah.
yes. Um, shall we go ahead with the presentation?
No, yeah, I'm. Is it my this problem or I your
Ma'am, you can ma'am, you can use the current slide, scan the current slide and
Ma'am, you cannot hear us, or
no now I can hear we can hear but it's intermittently just disappearing your voice. But now it's okay. Um, in the history, does anybody have anything to say? Burhan, do you want to add anything as to what intentionally what symptoms did you miss? To me, it appeared like a complete history. I do not know what you're implying. Maybe at the max, you did not mention about history of distant metastasis, is what I felt. But rest of it, I felt was quite a comprehensive history. You covered personal history very well. You covered symptomatology, so I directly kind of have made an impression of what subsite you're referring to.
yes, precisely we wanted to bring out that point, ma'am, that a detailed history can lead us to the possible site of the disease, and smaller details like what Deepika very detailed in a very concise manner she has mentioned. So those details are very imperative. But other than that, other constituting symptoms of pain,
Puran, can you come close to the microphone?
other constitution symptoms like pain, and the kind of where exactly the lymphadenopathy is, whether it is the concha, whether it is the medial ear, whether it is the tympanic membrane, the outer tympanic membrane, whether it is the atrium, whether it's different at the outer end, and the entire lymphadenopathy pathway should not be missed when we are speaking about symptomatology. So I would urge everybody to read the manual and take this as
Yeah, it is not audible. I agree.
can. Uh, am I audible? Audible now?
Now, yes, yes, yes. You have
Yes.
to be close to the microphone. There's something wrong with the
Yes.
this.
Yes. So
It's
I
not
think
picking up ambient sound. Huh.
okay, ma'am. So now, basically, I wanted to make this point is about the referred autalgia and the pain symptomatology, which is important. eh, in cases of CS supraglottis or otherwise. And when it comes to rhabdotalgia, it is important to ascertain where exactly the pain is. If the pain is either in the pain is whether the pain is in the concha, whether it is in the middle vein, whether the pain is in pain is in the tympanic membrane in the inner ear, and all this can lead us to probably the efferent and the afferent, as well as the pain pathway which is taken. So that can also give us an idea of where the disease lies. Apart from that, anything else? Mainly, there can be tongue deviation. That can be one. There can be extensive skin function, or that was a symptom which was not asked. That whether there was any pus discharge or any function place. Apart from that, I think most of the symptomatology was covered. Madam, should we go ahead with the
Yeah, yeah.
next?
I think let's proceed further. But there is one query by Dr. Rakesh who says, "How do you ascertain whether the patient needs tracheostomy or no?" So, Dr. Rakesh, that is an assessment you clinically make. If the patient is in stridor, obviously he needs tracheostomy. The reason why generally people defer a tracheostomy prior to taking up the patient for surgery, if he's a candidate for surgery, that is because it may, it can be a part of it can cause seedling. But tracheostomy, all said and done, is a life saving procedure. And if the patient is in stridor, he needs a tracheostomy. Another area where this has been of contention is when the patient is a candidate for non-surgical treatment. He's a candidate for larynx preservation, and the stridor is only because of the volume of the disease and not because of actual tumor infiltration. Then there is a case in point in giving neoadjuvant chemotherapy to the patient to avoid a tracheostomy. But that, I guess, let's keep that discussion for another session. Shall we move ahead then?
Yes, ma'am. I'll start.
Yes, yes, please. Go ahead, Shinjita.
Yes, ma'am. So, on general examination, the patient was conscious, cooperative, averagely built, and nourished with a BMI of 22, ECOG 0. Vitals were all stable. No stridor at rest, no pallor. On local head and neck examinations, the mouth opening was approximately 35 mm. There was no oral submucous fibrosis, no loose teeth. There were tobacco stained teeth. Oral cavity and oropharynx on examination were normal. No difficulty in neck extension. Laryngeal crepitus was present. There was no thyroid swelling. There was a right level 2 palpable lymph node, approximately 2 centimeter in size, form and consistency without any fixity to skin or underlying structures. So, there's a quiz as to what would be the choice of investigation for disease mapping in this case. You can
Before that, can I just intervene? I mean,
ye-
this was your inspectory findings, right?
yes, ma'am.
So you mentioned that you do not see any thyroid swelling.
Yes,
More
ma'am.
than a thyroid swelling, I would also be interested to know if there is any obvious extra laryngeal extension through the thyroid or through the thyroid cartilage. Why only a thyroid swelling?
Uh, yes, ma'am. I
Yeah,
missed
so
that.
many, yeah, many a time, hardly ever will the patient have a swelling in the thyroid gland which will appear. It will be a direct infiltration into the thyroid. What is of concern or can appear is an exolaryngeal disease, which is very much visible through at the level of the thyroid or the cricothyroid or even eroding the thyroid cartilage. So I guess that should be mentioned categorically.
Yes, ma'am. Okay, ma'am.
So yeah, join the quiz.
So everybody can scan this QR code and put the answers.
In the meantime, can you just tell all of us why you mentioned about neck extension and the presence of laryngeal crepitus? What does that indicate?
If there is a prevertebral fascia involvement, which would put the disease into a T4B category, uh, uh, there is the laryngeal crepitus is lost, and the patient will have a difficulty in extension of neck.
What is laryngeal crepitus and how do you find it? How do you assess it?
So we hold the larynx, and we move it in the we try to move it in the horizontal plane, as in over the pretracheal fascia. If it is mobile, and
Which fascia? Which fascia?
ma'am,
Which fascia?
prevertebral,
Prevertebral.
prevertebral. Yes,
Yeah,
ma'am.
yeah, yeah. Mm.
Ma'am, so if it is mobile, then laryngeal crepitus is present.
Yeah, and if it is not mobile, that means you would
There is
suspect
a
prevertebral
ma-
fascia infiltration, right?
yes, ma'am. Yes, ma'am.
I see everybody, nobody's responding to the quiz here. It's too high tech for everybody, I think. Oh, one response, I think.
Okay, ma'am. I
So,
participated.
so yeah, so I like this exercise, and but I think let's stick to the conventional. Is that okay?
Yes, ma'am. Yes, ma'am.
So, what is actually the investigation of choice?
Ma'am, in this case, we did a flexible uh, a fiber optic laryngoscopy.
And are there any studies to show that a flexible laryngoscopy is enough many a time and you do not need to combine it with, a direct laryngoscopy? Is that sufficient, flexible laryngoscopy, or do you need to, complement it with the DL-scopy all the time?
Ma'am, DL-scopy has its own advantages. There are some hidden areas of the larynx which are better visualized on DL-scopy. Wow. So then,
I will send you that link. You join.
Uh, Please mute yourself. It's
This
a kind
Nancy
request.
madam
Please.
join.
ma'am,
So, yeah.
yes.
So, what are the hidden areas? So, is it more important for hypopharynx or larynx?
Ma'am, it's more
This
important for hypopharynx
correct,
because,
correct,
yes, ma'am.
absolutely. I mean, many a time the supraglottis, some even glottis, should be, sufficiently assessed, can be assessed with a flexible, aided with your flexible biopsy, and by and large, you can avoid a separate general anesthesia with DL scopy. Yeah, but yeah, I
Yes.
agree completely. If it is extending to the hypopharynx, particularly because it matters the decision making as well as the extent of surgery and reconstruction matters. So in such situations, better to combine it with the DL-scopy. Apart from so in hypopharynx, what are the hidden areas?
Ma'am, the apex of the pyriform fossa and the post-cricoid area.
So tell us how will it change your management if it is involving the apex?
Ma'am, if it is involving the apex, then only doing a total laryngectomy will not suffice. We'll have to do a partial a pharyngectomy as well. And if it
No,
is
no, no, no. Hello. No, 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 no. Hang on, hang on. So the moment it goes into the hypopharynx, you are anyways going to combine it with partial pharyngectomy because hypopharynx obviously is a part of the pharynx, and you will have to. So you will have to take a part of the pharynx. What changes when the apex is involved, when the postcricoid is involved, like you right, them perfectly pointed out? What changes?
Ma'am, if apex is involved, then we might have to take we have to do a pairing. Ma'am, we'll have to augment it either with a gastric pull-up.
Perfect.
Yeah.
Absolute. No. Gastric pull up.
Ma'am, if we do it total, uh, we'll have to take a full thickness cuff. So we'll have to do ma'am, a patch pharyngoplasty in that case would
Correct.
not
Correct.
suffice. That,
No, 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 no. No, no. Array. So it's an unilateral thing, right? Unilateral apex of pyriform.
yes,
The
ma'am.
contralateral is normal, right? From your diagram, I can make out that is a unilateral disease.
Yes,
Okay.
ma'am.
So
Yes,
if
ma'am.
it is just going to the unilateral apex of pyriform, the apex of pyriform is very close to the upper esophageal sphincter.
Yes,
So
ma'am.
you will definitely need to patch it.
Yes, ma'am.
Probability of requiring a circumferential excision is when it there's a combination of post cricoid and pyriform apex.
Yes, ma'am.
But yes, you will have to make a decision with regards the reconstruction. So the moment
Yes,
it
ma'am.
goes to the hypopharynx, it has to be partial pharyngectomy. The hidden areas are essential to determine the reconstruction. But
Yes,
yeah,
ma'am.
I agree. If it goes into the apex and deeply into the apex, one must be kind of prepared for a circumferential excision as well. Okay, go ahead. Anybody has any comments to make till now, or we are on the same page, all of us? Same page, I think. Let's move on.
Yes. So, on fiber optic laryngoscopic examination, the epicenter of the disease was in the supraglottis. So, it was a submucosal lesion involving right-sided arytenoid, involving the right false cords and right true vocal cords, extending to involve the right aryepiglottic fold and medial wall of pyriform fossa. Anterior commissure was involved. A lateral wall of pyriform fossa appeared normal. Left-sided PFS and posterior pharyngeal wall appeared normal. Right hemilarynx appeared fixed. The chink was adequate and well compensated. BOT and vallicula were free and supple on palpation. And bilateral pharyngoepiglottic folds appeared normal. So, not a very clear video, ma'am, but so we can see the submucosal lesion on the right AE fold, which is involving the right false as well as true cord. There is no involvement of epiglottis, and medial wall of the PFS seemed to be involved, whereas lateral wall was free.
So this is one of the commonest presentations in our set of patients, right? You very
Yes,
typically made a mention of marginal zone. Can you just enlighten the audience what is marginal zone cancers?
Ma'am, so this was so ma'am, marginal zone is has a lot of submucosal glands. So the spread in this case is through the lymphatics, and it is generally
No, no, no. What is marginal zone?
ma'am, because the part of the hypopharynx also is involved in this case, as in the medial wall of the PFS is involved. That is why I call it a marginal zone cancer.
Correct. And why is it so common in our set of patients? This is a commonest subside, like supraglottis going and draping on the hypopharynx. Why? But it is kind of contradicting with the personal history that you mentioned. But let's see that later. Tell me, why is it commonest in our set of patients, marginal zone cancers?
Um, mm, I don't.
So typically, what is the commonest personal history that your patient will give you? So in
Um,
our set of patients, is chewing tobacco common or smoking tobacco common?
Ma'am, chewing tobacco is commoner.
Correct. And this chewed tobacco typically goes and drapes the supraglottis and the hypopharynx, as opposed to the West, where smoking is commoner, and hence glottic cancers are way more common than this marginal zone cancer. So, this marginal zone typically is a terminology which has arisen from our Indian subcontinent only. You'll never read marginal zone in literature anywhere. I mean, this is not the known subsite which is mentioned in the textbooks, right?
Yes, ma'am.
Having said that, your personal history your patient's personal history kind of contradicts the subsite. But I mean, I'm sure he must have combined chewed and smoked tobacco. So let's give that benefit of doubt. Yeah,
Yes, ma'am.
ठीक है. Go ahead.
So, ma'am, so we did a CCT neck and chest for this patient. So these are the images of CCT neck that I've put. To start with, the base tongue was normal on CT. The epiglottis seemed to be free. Here we can see the right-sided fold growth, which is going anteriorly as well as laterally, and involving the paraglottic space as well as eroding the thyroid cartilage, and has an extra laryngeal component here. Also, the patient had a right-sided level 2 node. The subglottis appeared to be free. We are again going up. Uh, so the subglottis was free. There's erosion of thyroid cartilage with an exolaryngeal spread, and the paraglottic as well as the preepiglottic spaces were involved.
But there is also exolaryngeal disease from the thyrohyoid membrane, right?
Yes, ma'am, there is.
Okay. And show us the piriform.
Ma'am, so here uh, the medial wall of the piriform was involved on the imaging, but the apex seemed to be free. So the
Absolutely. Correct.
Yes, ma'am.
Yeah. So can you just even point out where the pre-epiglottic space is for the benefit of all of us?
Yes, ma'am. So uh, So, ma'am, these are the paraglottic spaces, and it communicates anteriorly with the pre-epiglottic space,
Anteriorly and superiorly.
superiorly as well.
Okay. Anybody has any thing to mention or comment on the CT scan, or should we go ahead? I would urge all of you all to make to actively participate and make it more interactive. Maybe not with these fancy apps, but at least we can have some comments in the chat box, or pause and just speak on the microphone.
Uh, so, ma'am, this is a synoptic reporting. So, the epicenter of the disease was supraglottal, that is aryepiglottic fold. Right-sided disease dimensions were 2.4 into 2.3 into 3.9 centimeter. The epiglottis was free. Pre-epiglottic space was involved. Sorry for this error. Vallicula and hyoid were free. Medial wall of the pyriform fossa and A fold were involved. Lateral wall of pyriform fossa was free. Apex of pyriform fossa was free. Paraglottic space was involved. The false cord on the right side was involved, including the true vocal cord, anterior commissure, and posterior commissure were involved. Subglottis was free. Postcricoid was free. Thyroid gland also was free, and there was no pretracheal fascia involvement. There was thyroid cartilage erosion. Cricoid cartilage, however, was not involved. Cricoarytenoid joint was involved, and there was a exolaryngeal spread through the thyroid, as well as there was erosion of thyroid cartilage, which led to extension of the lesion into the right-sided strap muscles of the neck.
Okay, I like the synoptic reporting. Can you just make another comment of the degree of cartilage infiltration? Can you tell us what are the degrees of cartilage infiltration? Involvement, chalo.
Ma'am, so there is sclerosis, there is erosion, and there is encasement and displacement.
This. So generally, yes, sclerosis or abutment,
Yes, ma'am.
erosion and penetration. Penetration is what happens when it goes through and through, and it causes exolaryngeal through the cartilage, right? I mean,
Yes, ma'am.
typically that is the way the radiologists mention. This synoptic reporting is given by the radiologist only, na?
Yes, ma'am. So there's a paper by TMH group only, ma'am.
Uh-huh.
So,
No, so tell me, this is implied.
um, so ma'am, when there is uh, uh, there are changes in the as in there is abutment, and there is hyaline changes in the outer cortex, in the inner cortex of the cartilage. It leads to sclerosis. uh Ma'am, when there is
So can
uh,
you, if there is sclerosis, will you label it as T4 or T3?
ma'am, until and unless there is a marrow invasion, and the outer cortex of the thyroid is involved, it is only it's T3. Only if there is a outer cortex involvement, it is labeled as T4, T4A.
Yes, so inner cortex is still considered as T3. Yeah.
T3, yes, yes, ma'am.
So sclerosis amounts to T3. The moment it becomes erosion, it is
Yes, ma'am.
involvement of the marrow. Encasement is probably what you mean by penetration.
Yes,
Yeah.
ma'am.
And
Yes, ma'am.
displacement is when there is absolute fracture. Right.
Yes, ma'am.
Okay. Okay. Dr. Rakesh wants to know prevertebral fascia has not been mentioned. A prevertebral fascia is mentioned. It's free.
Yes, ma'am. It's free, ma'am.
Okay. Okay, go ahead.
So, coming to the end stage, so there was a presence of ipsilateral metastatic level 2 node. There was no necrosis, no perinodal spread, and no strap muscle involvement. Size of the node was around 1.3 centimeter. And we also did a CCT chest, so there were no lung nodules present.
Do you
So
need
there was
to
no.
do a very obvious CECT of the chest, or is there any other screening method of the chest when there is no obvious nodal metastasis, or you are not suspecting majorly lung infiltration?
So, ma'am, in this case, because we were doing a contrast enhanced imaging of the neck, we usually do it. The radiologist also gives us the cuts of the upper chest, but chest X-ray also can suffice, ma'am.
No, no. I mean, even the lung window, of a plain
Yes, ma'am.
CT
Yes, ma'am.
should be good enough many a
Yes, ma'am.
times to tell
Yes.
us. Yeah. Yeah, okay, go ahead.
I'll just skip
So,
this, ma'am.
uh, I'll just comment on what Rakesh has to say. What is the best test to rule out inoperability of CA larynx?
And just put this number. Simple.
Sorry, ma'am.
No, no, Dr. Rakesh has put in a comment on the chat box, and just to. So, what is the best test to rule out inoperability of CA larynx in terms of posterior extension, DL scopy versus CECT? Dr. Rakesh, posterior extension prevertebral fascia infiltration is a telltale sign in your OPD itself. You will be able to figure out if the patient is resectable or no in the OPD with regards the clinical signs. However, if you have any doubt, then obviously a combination of, because it is you're actually proving somebody inoperable when you don't have sufficient evidence in the clinic, as in clinically he doesn't look that obviously inoperable. So obviously a combination of CECT as well as DL scopy finding. I would combine the two to come to a diagnosis as to whether the patient is resectable or not. CT scan by and large gives us an understanding through the sagittal film if the prevertebral fascia is involved. As opposed to an MRI, sometimes an MRI can overestimate, but a CECT, if you corroborate your clinical findings and CECT, you should be good enough. But obviously, if in doubt, always combine it with the DL scopy. DL scopy is pretty safe and can help us give us more information as to whether the posterior pharyngeal wall is, fixed to the tuber is fixed to the prevertebral fascia or not. So now that you've put these three options, Dr. Shinjita, could you tell us why would you, add an MRI imaging in some situations?
Ma'am, MRI can serve as a problem solving tool in cases of cartilage erosion, uh, as well as prevertebral fascia involvement.
That's it. So what about cartilage involvement?
Ma'am,
What do you specifically want to find out on from an MRI as far as cartilage involvement is concerned?
MRI has better sensitivity for cartilage erosion because ma'am,
It tells us better about
the
marrow infiltration.
marrow infiltration. Yes, ma'am.
Yeah. If you want to make a decision with regards organ preservation versus surgery,
See, yes,
right?
ma'am. Yes, ma'am.
And you said prevertebral fascia.
Yes,
Why
ma'am.
a CT scan is good enough for a prevertebral fascia. You will add an MRI. Do you have any evidence to show or any studies which show that an MRI is preferred over a CT for a prevertebral fascia?
No, ma'am.
No, the problem with MRI is it tends to overestimate as well. So really, I'm not too sure whether prevertebral fascia is a criteria which MRI scores over a CT scan. I mean, I'll be happy to get any studies which you're aware of.
Ma'am, if we are doing an MRI, then that is an
No, no,
extra.
no, no, no. I didn't. Why? Mani, I'm asking you why will you do an MRI, not if you're doing an MRI.
Ma'am, my first choice of investigation would be a CCT neck in this
Agreed.
case. Mhm.
Agreed. Okay. Okay. When will you do a
Ma'am,
PET CT?
ma'am, PET CT can be done for residual disease post chemoradiation or
That is response assessment
yes, ma'am, for response assessment mainly.
per primum. Per primum.
Per primum, ma'am, if we are suspecting a metastatic disease, only then I would.
Correct. So which subside? Tell me.
Ma'am, supraglottis with and hypopharynx with.
Hypopharynx will be first on my list. Yeah.
Yes, ma'am.
Yeah. Okay. Let's move on.
Ma'am, so the next part of the presentation will be by Dr. Harsh.
So, Rakesh, minor cartilage erosion is difficult to detect on CT scan because, like Shinjita said, it is inner cortex, marrow, and outer cortex is what these are the three grades of infiltration of the cartilage. And that is actually a game changer. Till the time it is the inner cortex, you can preserve the larynx. The moment it goes beyond that inner cortex, you cannot preserve the larynx. And it has been shown that obviously marrow infiltration, like even in the jaw, in the mandible, marrow infiltration is better seen or more sensitively seen on an MRI. So if you have that critical decision making, you must add an MRI over a CT scan. Yeah, sorry, Shinjita, I missed what you said. Oh, next part of the presentation.
Yeah.
Yeah,
So,
please go ahead.
hi, hello everyone. I'm Dr. Harsh. I'm surgical oncologist from Tata Memorial. I'm now SR4 doing molecular and support. So
Hi,
I will,
Dr. Harsh.
hi, hello ma'am. So I will be dealing with the management part of advanced care larynx. So I will just describe the guidelines, what is the standard in
Your voice
supraglottic
is
disease.
not, no, your voice is echoing a lot.
Hello, is it okay?
Your voice is echoing. No.
Yeah, okay, just hello. Hello, ma'am. Yeah.
It's still echoing, but better than previously. Yeah.
So for a T4A increase.
No, your voice is echoing. Sorry. It's not clear at all. I think too many. I think Shinjita should turn off her microphone. Maybe I don't know. Maybe too many microphones in the same vicinity are turned on.
Yeah. Speak. Hello.
Yeah, better.
Yeah, I
Better.
think it's yeah. Thanks. So for a T4A, as like it's an our case, and for a N0T disease, M023, our treatment modality will be primary surgery, that is laryngectomy and thyroidectomy, and ipsilateral or bilateral leg dissection, depending on the disease status. Is it lateralized or is it in molecular decline? And the further plan will be depending on whether there are any high risk features in the post of HPR report is there, similar to other oral cavity cancers which we manage, like If their ENE is there or margins are positive, or if multiple nodes are positive, we will either go for CT-RT or for RT. Again, if the patient declines surgery, there are options for doing concurrent systemic therapy, that is CT-RT, or induction chemo followed by radiation. So coming to for tumors of larynx, this is the decision either to perform a total laryngectomy or a partial laryngectomy or supraprocoid laryngectomy, that will be decided by the surgeon, or depending on whether the complete tumor can be removed with a curative or not. Also, if it's a T4, N2, N3 disease, or those patients that are going to require adjuvant RT, they usually avoid any partial laryngectomy. That is what NCCN.
I'm sorry, your voice is not very clear. Again, you need to come close to the microphone.
Just a second. Hello. Ma'am,
Yeah, go on.
okay, sorry. And regarding the neck dissection,
So, may I just make a comment on the underlying statement that you made about partial laryngectomy versus total laryngectomy? I think let's, for the benefit of everyone in the audience, let's make it clear that partial laryngectomy and total laryngectomy are independent of each other. Yeah. So, if
so for a
Dr. Harsh, we've lost you. We cannot hear you very clearly.
Because they invade the site, and even if the
Dr. Harsh, your voice is not clear. We cannot hear you.
So I will just briefly describe evidence of doing the search in a case of T4A larynx rather than procedure. So when we looked at the study by Stokes et al. For cancer, they tried to orbit for like 1,500 patients.
Hello, Dr. Harsh, can you hear us, please?
Hello.
Yeah, we cannot hear anything what you
Is it audible?
said. Now you are audible, but we've lost you like almost 2-3 minutes back.
Hello.
Yeah, Dr. Harsh, we had lost you 2-3 minutes
Is
back.
it audible, ma'am?
We could not hear you when you started. So, अभी ठीक हो रहा है. तो
This is
वापस जाना पड़ेगा पीछे.
sorry.
वापस पीछे
Yeah.
जाना.
So, as I was talking, in the case of T4 ECL larynx, the general consensus is that surgery should be the modality of choice, because these tumors, they invade the cartilage, they did not respond well to radiation. And even if you are able to achieve a loco-regional control using a laryngeal conservation, most of the patients will be left with a non-functional larynx. There is a higher risk of poor airway and aspiration. If you give these patients with radiation, there is a chances that the cartilage will undergo endarteritis and there will be contour necrosis. So the chances of doing a salvage laryngectomy will be high. Also, these patients will have a higher risk of gastrostomach tube dependence. So these are the reasons why for a T4CL larynx, we do surgery as a primary modality. So I will briefly describe about the few evidences why surgery should be done for a T4 CL larynx rather than doing organ preservation with CTRT. So this is a study by Stoke. It's a HDB database of around 3,000 patients divided 1,500 to each arm for 2012. So they clearly said that combining CTRT was associated with inferior OS if you compare with a single modality like RT alone, also with ICRT. But overall survival, if you look, it is better superior in surgery with adjuvant RT rather than CTRT. And this paper is from MD Anderson by Senthal. They have done 3-decade survey of like 221 patients, and what they found is that the loco-regional control was better when surgery was done rather than doing a laryngeal preservation. Although in this paper, the median OS of was equal in both the arms. That is laryngectomy followed by surgery or laryngeal preservation using CTRT approach. The patients, those who underwent laryngeal preservation, the tracheostomy rate was 45%. Also, the aspiration rate was very high. And these patients have a high grade of dysplasia. That was what's during the follow-up of these patients. So these are also the reasons why you should not do a CTRT for these patients. And this is a recent article published in September 2022. And this says the number of patients which have become tracheostomy dependent following a organ preservation approach. So they analyzed a 6-year data of around 166 patients, in which they found that 18%, 18.7 patients require tracheostomy insertion. But if you see that decannulation of these patients was only observed in 12.9%, approximately 13% of patients had successful decannulation. So they said that decannulation was observed less successfully those with advanced or bilateral vocal cord immobile or those with tracheostomy inserted in emergency conditions. So even using this database, we can say that decannulation was very difficult. Only 12% patients achieved it. So organ preservation for a T4 larynx should be avoided. So the surgical options we have is either you do a near total or a total laryngectomy. So this near total laryngectomy is first described by Bruce Pearson. It's a voice conservation procedure in which we create a biological shunt between the remnant cricotracheal membrane and the cricoarytenoid unit. So it's a very dynamic because the nerve supply is retained and it is maintenance free. You do not require any maintenance or any external device for voice, and it is does not depend on doctor, and there is no recurring cost for it. So the indications for doing a near total laryngectomy will be those tumors which are well lateralized. So advanced lateralized tumors without involvement of any post-cricoid mucosa or interarytenoid area, and one cricoarytenoid unit should be preserved. In those cases only you can do. If the tumor is involving the midline or interarytenoid region or post-cricoid region, or if the mucosal involvement is more than 1/3 of the contralateral vocal cord, so that the vocal cord remnant becomes insufficient for any shunt surgery. And if the patient has been given prior radiation, in which there will be edematous tissue, this is a relative contraindication to do a near total laryngectomy.
So, Dr. Harsh, what is this shunt typically called that you mentioned?
Because I would say the voice quality outcomes may not be similar to what we while.
Dr. Harsh, can you hear us?
Yes, ma'am. Yeah, I can hear you.
Yeah, so I said, what is this shunt typically called? You know, the shunt that you very rightly mentioned, no? It is a shunt which is made out of the residual functioning cricoarytenoid. What does the shunt comprise of?
So, ma'am, that the cricoid and trachea is connected. Basically, we create a biological shunt.
Cricoarytenoid, yes, biological shunt. So it is typically called as a myomucosal shunt. It has the muscle as well as the mucosa. Yeah, and the functioning cricoarytenoid joint.
Yes.
right? And a functioning ipsilateral recurrent laryngeal nerve, obviously,
Yeah, yeah. Because
for obvious
we have
reasons.
preserved one side. Yeah, for obvious reason. Yeah.
Yeah, yeah, perfect.
Yeah. Uh, so coming to total laryngectomy, the indications is when the laryngeal framework is involved or the cartilage is involved. If the larynx is dysfunctional, if there is a risk of aspiration, vocal cord fixation, there is an extensive submucosal spread of the disease, or if there is a recurrent or residual disease after organ preservation. So contraindications will be like if, if the patient general condition is very poor for the surgery, or if there is a functional larynx without cartilage erosion in which we can actually preserve the larynx, or if the disease is very extensive that superiorly goes to oropharynx or go to prevertebral fascia or carotid encasement, if the disease is metastatic, and obviously on patient preference. So I have a quiz.
So, is anybody aware of any studies? You know, you mentioned patient preference a couple of times. Do you have any studies to give us an idea as to what does the patient prefer? He prefers conservation of the larynx, or he prefers a total laryngectomy? I mean, are there any questionnaire-based studies where you know this has been assessed?
I'm not aware of those studies, but most of them will be, uh, if option is given for voice preservation, then they will be more preferred. But I'm
Really?
not exactly sure of the studies.
Yeah, yeah. So that's what there are questionnaire based studies which were done, which is a lot of study questionnaire based studies to look at patient preference, also to look at clinician preference, you know, what they prefer to offer to their patients. That is a secondary issue, but what the patient also prefers. So it will be nice if one of you, you know, either you or Srinjita or Dr. Burhan, you know,
Okay. Okay.
since you've taken up this topic, could enlighten us with these the studies. So later, you know, in
Yeah,
this
ma'am.
coming
If
week,
you
if
are
you could
available, I
just
will
tell
share
us,
with you. Yeah, yeah.
yes,
Yeah,
yes, do that. It'll be interesting to know.
surely. So the question is routine thyroidectomy indicated in all cases of advanced laryngeal cancers? So what is the Paul's opinion? Will you do for all cases or for selected cases? Okay, I think I have to move on. So I think 50-50 answers are there. So I will just come with evidence.
So with who are these 50 and where you will do and which are the 50 you will not do? I think give us
Yeah,
an,
yeah.
you know,
I will just
understanding
let
of
you.
it. Yeah.
Yeah, yeah. So I'm showing one study, the systemic review and meta-analysis, in which they have discussed about thyroid cartilage innervation in total laryngectomy patients. So it is a 25 studies meta-analysis with 2,107 cases. So they have found that only 8% of the patients, that is 176 people, had thyroid invasion. And they have given a risk thing. That, for example, those tumors which have subglottic extension or subglottic tumors or at T4 stage advanced or thyroid cartilage invasion, they are a risk factors for thyroid invasion. And that there was no difference noted even if the tumor is recurrent and its association with an thyroid invasion. The other study which I am showing is a randomized control trial from Egypt. So they have studied on 100 patients over 5 years, and they classified them into two groups. Either they will do thyroid sparing or thyroid sacrificing. So in terms of the oncological control or tumor recurrence, there was no statistically significant difference between the two groups. So others have concluded that if there is subglottic extension or thyroid or required cartilage invasion or true invasion of thyroid gland, you can take the ipsilateral side of thyroid. Otherwise, for oncological purposes, a routine thyroidectomy is not indicated if these high risk factors are not there. So coming to the post-laryngectomy rehabilitation, So for a larynx, we have to rehabilitate the patient's speech, his swallowing, his emotional, social, and occupational outcomes. So most commonly in speech, there are esophageal, tracheoesophageal prosthesis, and artificial larynx in terms of electrolarynx or pneumatic larynx. So this is a broad classification. How will you rehabilitate the speech based on non-surgical and surgical methods? Non-surgical includes esophageal and mechanical sound devices like artificial larynx. Surgical methods includes creation of shunt, which is either external or internal shunt, either without or with processes. So the esophageal speech in the this is the mechanism how it happens. The air is swallowed and it's expelled to vibrate through the PE segment, which is articulated into speech. So the issues with esophageal speech is the training is very difficult. Only 20% of the patients actually acquire communicable speech, and the speech is very low frequency. It's not intelligible. Also, in noisy environment, you cannot hear the voice, and the phasing is difficult because the reserve is only 80 ml. So this is not a preferred modality for most of the patients. Other is the mechanical sound sources, either use electrolarynx, which can be either transcervical or transversal. So this can be used against the neck or used the intraoral ones. So here the advantages is the learning time is very short. You can get immediate results, and it does not delay or interfere with other forms, like does not delay any healing or anything. Disadvantage is battery dependent. The sound quality is very mechanical and is hand operated and conspicuous in nature. Coming to the popularly used shunt surgeries. So for a normal voice, you require a initiator, a vibrator, and a resonator. Like when the larynx is removed in the shunt, initiator becomes your lungs only. Vibration is by the PE segment, and the resonator will be by the recon or the oropharynx or oral pharynx, which will be done. So this is the mechanism, that is the air which is exhaled from lungs. It is diverted into esophagus through the fistula, through the PE segment resonation and modulation, and the new glottis is set into vibration. So patient selection for TP is very important. That it should be motivated. A preoperative counseling should be done for all the patients. So they should have a stable mind, no, not alcoholic. They should understand what process we are going to undergo. Good visual and hand dexterity is important. The air insufficient test should be positive. There should not be any pharyngeal stricture or stenosis. Stoma should be of adequate size, intact, and the party wall should be intact. Also, the pulmonary reserve should be good for these patients. So the types of TEP can be two types. It can be either a primary TEP that is performed during total laryngectomy, that is the first surgery, or secondary, in which we perform after 6 months of the surgery, that is after the healing has occurred. And the voice processes can be indwelling or non-indwelling. So indwelling are those which are left in place for 3 to 6 months, and it is done by the doctors only. It requires less maintenance. And non-indwelling are those which patient can do by themselves, and it should be removed and cleaned through a couple of days. It requires a periodical maintenance. Both of them, the stoma size should be more than 2 centimeter, and the esophageal insufflation size should be positive. So these are some of the examples of non-indwelling and indwelling prostheses. Commonly Provox and Provox Vega are indwelling prostheses we use. So one question, which is the preferred modality? If the patient comes, whether you will go for a primary or a secondary TP, or does it depends on the physician preference whether a primary or secondary TP to be done? Is there a logical reasoning behind doing a primary, or are there any studies which shows superiority or inferiority or non-inferiority between these two? Yeah, so I will just Go ahead. So these are the few studies. These are the meta-analysis of 37 retrospective studies published in 2017 in South by Brazil group. So they divided cases into TEP1 and TEP2. That is primary is TEP1 and secondary is TEP2. They wanted to compare the complication and success in the rehabilitation. So they have said that if you do a primary TEP, the rate of leakage was high, 22% versus 6%. Wound infection was high, 9 versus 3%, and tracheal stenosis was 8 versus 4.5% when you compared with a secondary TP. But these numbers do not reach any statistical significance. But the author have concluded that there is a reduction in risk of leakage if you do a secondary TP by around 10%. But this is not a statistically significant. This is one study in 2017. The other one is by Lu et al. It is 2018. This is also a systemic review in which they have compared 11 retrospective studies. 9 studies do not found any difference. 2 studies found higher rates with primary TP than rather than secondary TP. And the VOWS outcomes, which was the primary measurement, it was inconsistently measured, and there is no difference between the groups in the 4 studies. So there is a no robust evidence to suggest that primary TP is associated with poorer outcomes compared to secondary TP. So primary TP can be considered for our patients. So what are the problems which inquire with tracheoesophageal prosthesis? These are the 4 main common. Either the location is improper, or if the size of the puncture is improper, or if there associated cricopharyngeal spasm, or if there is a leakage through or around the prosthesis. So we'll see some troubleshoot solutions. So if the valve is in contact with the posterior wall, you have to replace the prosthesis with different length and size. And sometimes the prosthesis length is very short. It is a pinched wall. So you have to remeasure the puncture side and use appropriate size. If the valve is deteriorated, the valve needs to repair. And for fungal colonization, treat with nystatin. If there is a back pressure changes, you have to do high resistance prosthesis. Other is mucous foot dislodgement, for which the process needs to be cleaned. If the TP location is inappropriate, you have to remove the processes and allow the puncture to close. Also, if there is an unnecessary dilation, should be avoided. If the party wall is very thin, you have to use a custom prosthesis. If the size and length is incorrect, then accordingly you have to use the correct length and use a custom prosthesis. The other thing is pulmonary rehabilitation. Now, since you know the larynx is important for the humidification and for the proper ciliary functions. So once the larynx is removed, the ciliary movements are altered and there is a metaplasia of respiratory epithelium, because of which the patient complains of more and more cough, there will be sputum production, there will be nasal discharge. And his PFTs will be abnormal and the quality of life is QL. So we use a heat moisture exchange, which is a foam of paper that act as a absorbent, because it is impregnated with hygroscopic salts like calcium chloride and magnesium chloride. So this helps in humidification of area. So that helps for his proper voice and reduces the sputum production. The other thing is a swallowing rehab, which these patients require. And it is said that even 98% of the patients experience swallowing difficulty. And the reasons can be because of the altered pharyngeal musculature, if there is an associated cricopharyngeal spasm, because of the nature and extent of surgery, surgical closure, and radiotherapy. So when you are closing the larynx, the unstretched mucosa should be minimum 3 centimeter for a primary closure. If you do too tight, then the patient will have dysphagia and swallowing problems. So how will you diagnose it? So this is by modified barium cello. We have to do a video fluoroscopic assessment, and other is fiber optic assessment. So what are the different findings you get? So either the P segment is tonic. So when you do a barium solve over a phonation, the food passes easily, and the voice is good. If it is hypertonic, there will be slower passage, and the voice will be intermittently tight. If there is a stricture, there will be permanent hold up. There will not be voice. So for a hypotonic segment, you have to use a tracheoesophageal valve with distal pressure. And for hypertonic segments, you have to do a pharyngeal myotomy or a botulinum neurotoxin injection. Again, for a spasm, same pharyngeal constrictor myotomy can be done. And for strictures, you can remove that part and do a pharyngeal flap augmentation. Thank you.